Madam, we are live now.
Okay.
So good evening, doctors and all the participants. Shuman on behalf of Shield Healthcare, welcoming you all in today's another very interesting and important topic, that is adolescent PCOS. And our guest speaker is Dr. Shamstuti Patnaik, madam. So it's my honor to introduce madam. Madam is the consultant obstetrician and gynecologist and laparoscopic surgeon and infertility specialist at Shanti Memorial Hospital, Rourkela, Odisha. Madam did her fellow in minimal access surgery, fellow in reproductive medicine, and fellow in fetal medicine also. Apart from that, in terms of academic activities, madam is really engaged in many other activities. She is the speaker of many national and international conferences as well. So with this short introduction, I request madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with madam. So thank you very much, madam, once again for your valuable time in our Shield Connect platform, and over to you, ma'am, for further postings. Thank you very much.
Yeah, is it visible?
Yeah, it's okay.
Am I audible also?
Sure.
Yes, ma'am.
Yeah, okay. Okay. Yeah, I think now it's better.
Yeah, it's okay, madam.
Yeah, okay. I'll share the screen.
Madam, actually, yes, it's coming fine, ma'am.
Oh, it's fine, right?
Sure.
Yes, ma'am.
Yeah, okay. Yeah, that's the first slide. Is it all fine?
Yes, ma'am.
Fine.
Okay. Okay. So very good evening to one and all. Thank you, Shield, for giving me this wonderful opportunity to speak on something that becomes very, very difficult for us to see in the OPD, that is adolescent PCOS. I think we all face a lot of difficulties when it comes to this thing. PCOS as such is a very huge subject, but adolescent PCOS is something that becomes very difficult to treat, diagnose, and manage, because it is there are a lot of things involved in it regarding underdiagnosis, overdiagnosis, and other things. So we would try to see what all current evidences say, what all recent advances say, and how we can go about it. So coming to the what do you mean by adolescence? From Latin, adolescere means to mature. The phase of life between childhood and adulthood from ages 10 to 19, according to WHO. Adolescence, that is the unique stage of human development and an important time for laying the foundations of good health. India has the largest adolescent population in the world, 253 million, and every fifth person is between 10 to 19 years. Adolescents experience rapid physical, cognitive, and psychosocial growth. So, this age group is something that is very difficult to deal with. And why is it important in our Indian scenario? We've already seen it, around 253 million people are there in this adolescent population. And we go through a lot, they go through a lot of changes, and there are a lot of challenges in this, not only for the Department of Gynecology, but also in the branch of pediatrics. So what is adolescent PCOS? It is unexplained persistent hyperandrogenic anovulation, according to American Academy of Pediatrics 2015. What are the various risk factors? Premature puberty, that is less than 8 years, obesity, family history, ethnicity, common in African and American population, much more common in their population. So these are the various risk factors that we see, and we have to be very careful when such a thing exists, and how we are going to go about the diagnosis of PCOS, and what we are going to keep our mind while branding or labeling someone as PCOS. Coming to the prevalence, around 2.2 to 18% depend, on the diagnostic criteria or the ethnicity. With strict NIH criteria, as we know, there are many criteria that are being developed, and so many comparisons that are happening. That is Rotterdam criteria, NIH criteria, and others. So 6 to 8% prevalence according to the strict NIH criteria, 15 to 25% according to Rotterdam criteria, which is a little lenient. And the prevalence is increasing because of the increasing prevalence of childhood obesity and the improvement in diagnosis. But one thing that we are going to be very concerned here is about the overdiagnosis, which we are seeing every now and then, and we have to prevent it. We have to know what we are going to see in our OPD, what are the investigations we are going to write, so that we do not underdiagnose, we do not overdiagnose, or we do not misinterpret. And the differential diagnosis of PCOS also has to be done in a proper way, especially pertaining to hyperandrogenism. The disrupted hypothalamic pituitary ovarian axis, it leads to PCOS in the women. Before I go into that, there are, I just recently went through a talk from people in the Aspire 2022 from, South Asian countries and China and other things. There is so much work that is happening in epigenetics and progenetics, so many genes that are involved, which lead to a PCOS phenotype in a woman. So it is, before the disruption of the hypothalamus pituitary axis, there are so many genes, so many mutations, so many things that are involved in it. I think that is a very different molecular level and pathophysiology of PCOS, which needs a very different presentation to speak about it, because there's so many genetic modulations which lead to that. Coming to what causes the disruption in the HPO axis, which leads to PCOS in women, we have hyperinsulinemia, hyperandrogenemia, dyslipidemia, disturbed gut microbiota, obesity, and inflammation. There is a silent, or you can say a hello.
Yes, ma'am.
Hello.
Yes, ma'am.
There
Yes, ma'am.
was a problem. Yeah, I'm so sorry, because what happened, there was a problem with the internet. So I'm sorry, I'm going to share it again, but I'm doing it so there would be a problem anymore.
Yes, madam. So
Just
bandwidth, it is showing
1
that
second.
your bandwidth is low, ma'am.
Yeah, now.
Voice is breaking, ma'am. Madam, we couldn't hear you properly. Aditi, can you hear?
No, sir. Voice is breaking little bit.
Actually, today may be some network problem.
Network issue is there.
Yes, yes.
One second, I'll just. Yeah, can you hear me now?
No, ma'am, bandwidth is low. It is showing bandwidth is low and nothing is coming. His voice is also breaking.
One second. Yeah, just
Ma'am,
1 minute. 1 minute. Abhi. Yeah, just 1 second. 1 second. I'll just, switch on the current was not there, so Wi-Fi is going to get switched on.
I understood. We understood. No problem. No problem. Sure.
Is it switched on or what? Is it because mobile data में नहीं हो रहा है ना? So it's connecting. It's not getting connected. Hello?
Yes, madam. Now
Yes,
it is
ma'am.
fine. It's fine.
Now?
Now, ma'am, it is fine.
Can you hear me now?
Yes,
Yeah,
ma'am.
ma'am, we can hear you.
Yeah, you can hear me now?
Yeah, madam, you can share the screen, ma'am.
Yeah. One second. Is it visible now?
Yes, madam.
Yes, ma'am. It is visible.
Yeah. Yeah. Can you hear me? Is it visible?
Yeah, sure, ma'am. It is visible.
Yes, ma'am.
Yeah. Yeah. Sorry for the trouble because of the internet, because of the issue in the current. So we'll continue. Coming to the symptoms and the risks of PCOS, as we all know, very generally, the symptoms like what we see are hirsutism, acne, insulin resistance, weight gain, fertility problems, irregular or non-existent periods. The various risks that we see that we have to be very particular why PCOS is important for us. That is anxiety, stress, depression, obstructive sleep apnea, cardiovascular disease, type 2 diabetes, and obesity. Symptoms and their frequency in PCOS in adolescents. As we can see, what are the major symptoms that we see and what percentage of women we are going to see it. Menstrual cycle disturbances are found in 70% of the women. Oligomenorrhea in 50%, amenorrhea in 10%, abnormal heavy bleeding in 10 to 15%, hyperandrogenism we can see again in around 70% of the women, acne, under that criteria we may see acne in 70%, hirsutism in 70%, alopecia 10% as seen by the gynecologist. Dermatologists feel alopecia is not all that uncommon, around 20%, and acanthosis nigricans, which we can see big marker of insulin resistance and other things, PCOS and around obesity around 50 to 60% among all the symptoms, and normal menstruation also we can see in around 20%. Is it all fine? My audio, video, everything is okay?
Hello?
Yeah, ma'am, it is okay, madam. Okay, ma'am. Please continue, ma'am.
Okay, no?
Please continue, madam. Everything is okay.
Yes, ma'am, it's moving.
Okay,
Yeah, please
okay, fine.
continue.
Yeah, so where is the dilemma? Why are we so concerned about the various risk factors, the pathophysiology, the various other risks, or the sequelae of PCOS? What is going to happen? It is because of the overdiagnosis that is happening. Anybody coming with an irregular menstrual cycle or something, we stamp it, or being a little overweight or something, we stamp it as a PCOS, which is not always true. And also underdiagnosis of PCOS, when we take into all these factors, the ultrasonography factors, the hyperandrogenism, the biochemical factors, and the history and other things, we have to create our own set of criteria, I feel, in our practice, in our day-to-day practice, for knowing in which age group what we are going to look for, how many years post menarche what we are going to look for, and what should be the length of the menstrual cycle, and how many irregular cycles we are going to have. Then only we are going to decide that we are going to label this person as PCOS, or we have to keep it in our mind that these are at risk PCOS ladies, so that with regular follow-up and everything, we're going to see whether she is developing the PCOS phenotype and other things, or whether we have some other differential diagnosis like other adrenal virilizing tumors, or adrenal hyperplasia, or other things which are involved, or simply other ovulatory dysfunctions and other criterias which are involved, and not just PCOS. So the diagnosis of PCOS in adolescents should be primarily based on the clinical and biochemical signs of hyperandrogenism and presentation with irregular menses. Because of the similarity of the normal pubertal development and features of PCOS, the diagnosis should be deferred until at least 2 years following menarche. As we know, the various criteria that have developed, I'm going to talk about it also. Within 1 year of menarche, of course, we are not going to consider it as PCOS. We have to wait, and it can be normal pubertal dysfunction that is happening. Beyond 1 year of menarche, we have to start being careful. 1 to 3 years following menarche, how we are going to see the cycles. Post 3 years of menarche also, it becomes very, very easy and a definitive diagnosis of PCOS. For girls who do not fulfill the diagnostic criteria, the focus should be on the treatment of the symptoms. The physiological changes, what do we see in adolescents? In this, we have hyperinsulinemia and insulin resistance that is exaggerated by the genetic factors and or obesity if that exists already. Hyperpulsatile gonadotrophin secretion, hyperactive ovarian androgen synthesis, hyperactive adrenal androgen synthesis, menstrual irregularities, decrease in the level of the IGF-BP1 and sex hormone binding globulin. These are all the things that we can see in this. So increased insulin levels, IGF-1 activity, androgen during puberty probably are inducing factors in development of the PCOS. These are the various inducing factors that we see, and there are many other mechanisms, as I said, the epigenetic and progenetic factors, the phosphatidyl ionocetal 3 kinase involvement and other things which we are going to see. These are many factors which can be triggers to the development of PCOS. After puberty, insulin and IGF-1 progressively decreases in most females, so leading to normalcy. Menstrual irregularity, menstrual problems are present in 80% of the obese PCOS and 30% with the lean PCOS. See, it becomes very easy for us when it comes to an obese PCOS group, as we can see all these problems. We find hyperandrogenism, we find ovulatory dysfunction and other things. But our problem comes when it comes to the lean PCOS, because of course, lifestyle management also has an effect and exercise also has an effect, but reduction of weight and other things cannot be pursued in that. So lean PCOS is another huge topic which we can take up as a different subject, and how to deal with the lean PCOS patients. 20% of the PCOS patients have normal cycles. So this is something very, very important for over and under diagnosis of PCOS, that we have to accept that around 20% of our patients may have normal cycles. It is well accepted that if menstrual irregularities persist for 2 years after menarche, then the risk for PCOS is extremely high. That is around 70% of the cases. As I said, 1 to 3 years, we have to be very particular, especially 1 to 2 years. That period should be, it has to be in our mind that at risk PCOS patients who may develop into PCOS later, more than 2 years or more than 3 years, definitely it becomes very high and the diagnosis becomes more definitive in that way. So in adolescents, polycystic ovaries, the prevalence of polycystic ovaries increases throughout puberty. So that is the reason why transvaginal sonography or any other ultrasound diagnosis of PCOS is not considered within 8 years of menarche or whatever, because in normal
development of puberty, we do find presence of multicystic ovaries in adolescents. So that cannot be, the sonographic picture of the ovaries cannot be a criteria for diagnosing or labeling them as polycystic ovaries. That is what we have to keep in our mind. So 6% at 6-year-olds, 26% in 15-year-olds, the prevalence of polycystic ovaries and the presence of this multicystic polycystic ovaries does not tell you that the person suffers from a polycystic ovarian syndrome. All PCOS patients are not the same. All patients do not have the similar symptoms. Some are thin, some are obese, some having acne, hirsutism, some don't have it. Some will have polycystic ovary on sonography, some are not under Rotterdam polycystic ovarian morphology, which is defined as a follicle number per ovary of more than equal to 20 and or ovarian volume of more than 10 cc in at least one ovary. Some have insulin resistance, acanthosis nigricans, some do not have it. So there are many varied pictures. As I said, we have to make the various consensus that are there, whether that is a Rotterdam or an NIH or an ASRM and others. So many guidelines are coming every now and then. So we have to deduce our own guideline and a criteria and seeing our patients in the OPD, what to see, what not to see, and how to label it. So the criteria for diagnosis of PCOS, the diagnostic criteria sets of the polycystic ovarian syndrome, as we can see, if we see and compare all the criteria, that is NIH, Rotterdam, and the Androgen Excess and PCOS Society 2006. So we have a hyperandrogenism, whether that is clinical or biochemical. Clinical, as we can see, it can be acne or hirsutism. Hirsutism, there are, as we know, there is Ferriman-Galway score. We can take the cutoff as some take it as 4 to 6, some 6 to 8, and then to brand it as hirsutism. We have acne with many criteria for the comedonal cones and other things. So that is clinical. Coming to biochemical hyperandrogenism, that can be a total free testosterone estimation or androstenedione or a 17-hydroxy progesterone or the other estimation. So considering these two factors, we have it in NIH criteria, we have it in Androgen Excess and PCOS Society 2016, but we may or may not have it in Rotterdam. Ovulatory dysfunction, again, it is there in the strict NIH criteria, which can be, cannot be in the other two. Polycystic ovarian morphology, it is may or may not be, as we can see in the Rotterdam and the other one. Diagnosis statements, hyperandrogenism and ovulatory dysfunction are indispensable features. In Rotterdam, we have any 2 of 3 features out of HA, OD, and PCOM for diagnosis. In Androgen Excess and a PCOS Society, we see hyperandrogenism is the indispensable feature, and ovulatory dysfunction and or PCOM should be accompanied. Everything is fine? My audio video?
Yes, madam. Everything is fine.
Okay, so coming to the phenotype distribution, as we have nowadays, I'm seeing there are many presentations in which we have a female phenotype of PCOS, we have a male phenotype of PCOS, separate presentations are being made into it. So why is that important? The phenotype is so important. As we can see, we have 4 phenotypes here. The first one being the full-blown PCOS, in which we have HA, OD, and PCO, which is hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. And we see it among 67 to 70% of the women, the full-blown PCOS. Coming to B, phenotype B, that is non-PCO PCOS, that is just HA and OD. Ovulatory PCOS, that is HA and PCO that we see, that is in around 30%, 29 to 30% of the women. Coming to the non-hyperandrogenic PCOS, in which we just have ovulatory dysfunction and polycystic ovaries, we find it in around 3 to 4% of the women. So this is how we can see the phenotypes being distributed, maximum one being the full-blown, followed by ovulatory PCOS, as we have already spoken that, the normal regular cycles do happen, ovulation happens in 20 to 30% of the women, followed by non-PCO PCOS, in which we do not find polycystic ovaries, but we do have hyperandrogenism and ovulatory dysfunction, followed by very less proportion of this being non-hyperandrogenic PCOS. So that is why hyperandrogenism is an indispensable factor in many of the consensus and guidelines that we are seeing nowadays. So the current recommendations: wait 2 years after menarche before making diagnosis. Some wait just for 1 year, and after that start becoming conscious and make it as at risk. Refrain from diagnosis in doubt to avoid the occurrence of anxiety and depression, because these features and the diagnosis in women in OPD that I have PCOS, that is why I'm having hair loss, alopecia, I'm having hirsutism, I'm having acne. So that leads to more anxiety and depression than the PCOS itself. So the symptoms can lead a woman to think in that way, have a negative image about herself and other things, and lead more to anxiety and depression rather than the normal emotional non-well-being that happens in PCOS. Evaluation of metabolic status in presence of obesity and or hyperandrogenism, early treatment of hyperandrogenic and metabolic symptoms also before the diagnosis. Consider carefully, the ultrasound data, and when to consider the ultrasound data, what period after menarche we are going to consider it, and what age. That is also equally important. So as we can see here, diagnostic criterion for PCOS in adolescents, especially in adolescents, this is something that has been made for adolescent group, not the general PCOS group as such. And we've already spoken adolescents, that is 10 to 19 years of age group, in which we find various other things, and how we are going to deal with the diagnosis of PCOS. All the three things are there, then definitely it is there. Diagnosis of PCOS probable but not confirmed. If we have hyperandrogenism and chronic anovulation, polycystic ovaries, we may or may not see, because usually we do not consider it as the thing. Diagnosis of PCOS not possible during adolescence. That obviously we have hyperandrogenism and polycystic ovaries in it. Then not PCOS if just we have either of the three. If we have only hyperandrogenism, if we have only chronic anovulation, if we have only polycystic ovaries, we definitely need some clinical correlation and corroboration before branding it as PCOS. So the recommendations for the diagnosis of PCOS in adolescents, presence of oligomenorrhea or amenorrhea beyond 2 years of menarche should be considered an early clinical sign of PCOS, followed by Rotterdam criteria of adults for diagnosis of PCOS, androgen excess, biochemical, that is serum, total testosterone, free testosterone, and other things clinically, as I've already spoken about all this: acne, hirsutism, female pattern hair loss, ovulatory dysfunction, PCO with strict interpretation of ultrasonography findings. Diagnostic test, what are the various diagnostic tests for PCOS in the adolescents? Minimal diagnosis of PCOS in adolescents should include 5 tests, that is serum total testosterone cutoff being 60 nanogram per deciliter, OGTT at 0 and 2 hours post 75 gram glucose load, serum 17 hydroxyprogesterone assessed in the mornings, preferably around 8 o'clock, serum TSH, serum prolactin levels. For the diagnosis of PCOS in adolescents, serum LH, FSH, and cortisol should be assessed as indicated. Healthcare providers should assess the early signs of insulin resistance and metabolic syndrome. That is also equally important. So these are the various normal tests that we usually write in our OPD, just to assess what are the things, whether there's hypothyroidism, hyperprolactinemia, or there is a deficiency of 17 hydroxyprogesterone, or the OGTT, we find insulin resistance in it, or a total testosterone, the cutoff being 60 nanogram per deciliter. So that has to be in the back of our mind when we are seeing an adolescent PCOS girl coming in for us. So endocrine criterion already mentioned, LH, FSH values have to be seen, estradiol value, TSH value, prolactin value, and maybe anti-Mullerian hormone can also be done to corroborate. So ovarian androgens, what are we going to see? Testosterone, androstenedione, free androgen index, in which I would like to say that androstenedione and DHEAS are more for confirming that it is not a PCOS and rather indicating towards an adrenal hyperplasia or virilizing tumor. So that is when they come into the picture, and that is when they help us in the differential diagnosis of the hyperandrogenic PCOS. The metabolic aspects, of course, if you are already finding obesity, there's a family history, there's metabolic disorder already there, there's a type 2 diabetes, because so many pediatric diabetes type 2 girls are having PCOS, because it is increasing, it is on the rise. It's not like type 2 diabetes mellitus is coming in the midlife or anything else. The pediatric age group having type 2 diabetes mellitus is slowly increasing more and more. So we have to be very careful about all these factors if they're existing in it. Metabolic syndrome also. So the evaluation, cutaneous manifestations, physical examination should document the cutaneous manifestations, terminal hair growth. We can also put it in the Ferryman-Galway square on the 10 places that we can see, like our back or upper chin or upper lips, and on the chest, upper chest, lower abdomen, and other areas that we can see where we have to go for it. Acne, alopecia, Acanthosis nigricans, skin tags. As we know, the dark coloration in the folds, acanthosis nigricans, and various skin tags. So this is according to the Endocrine Society Clinical Practice 2013. These are the various cutaneous manifestations that we can see and think of PCOS. Obesity, increased adiposity, particularly abdominal, is associated with hyperandrogenemia and increased metabolic risk, in which waist to hip ratio is also very important, 0.8 being a cutoff for females. Screening for increased adiposity by BMI calculation. We can check the BMI body mass index or the measurement of the waist circumference, as I said, waist to hip ratio. This is also according to the Endocrine Society Clinical Practice. Depression, this is another emotional aspect, or the emotional well-being also is equally important and signals towards PCOS. Screening for depression and anxiety by history, and if identified, there has to be a proper referral, and this aspect also has to be taken care, because it may get worse. It may create a negative balance and negative, very bad quality of life in a PCOS women, and it has to be treated in the proper way. Rescreening, as I said, we have to label some people at risk for PCOS women and others every 3 to 5 years. More frequently, if there is central adiposity, there is substantial weight gain, there are and or symptoms of diabetes also develop. So these are the things in which we have to rescreen. We have to ask the patient to keep on coming to us, a regular follow-up, so that we do not miss it, that a patient develops PCOS later. Coming to treatment, there are various lines of therapy, as we know. So before I go to the treatment, I would like to speak something about the diagnosis. I've already spoken about all that clinical, biochemical parameters, what tests we are going to see, why we are going to see certain tests. And the major thing that I want to highlight here also is the irregularity of the menstrual cycle. As you know, it has been there. So less than 1 year, we are not going to be bothered. We are going to wait for 1 year post-menarche. Again, this is, I'm talking about post-menarche. Less than 1 year, we're not going to bother that much. But more than 1 year and less than 3 years, definitely we have to see if it is, 21 to 45 days, it's okay. If it's more than 45 days or less than 21 days, or we can broadly say more than 8 cycles per year being irregular, that is important. More than 3 years or post-menarche, it is the usual that we take. 21 to 35 days is okay, but this is the new criterion that has come. 21 to 45 in the 1 to 3 post-menarche. In more than 3, it is 21 to 35. And of course, when it comes more than 3 years, any a cycle which is more than 90 days, any one cycle, that is also considered. So this is something about the irregularity of menstrual cycle where I go. We have talked about the acne. As we can see, there are various criteria also nowadays, at least 10 comedonal cones that we can see, and all various things are there. Acanthosis nigricans, of course, it is a very great indicator of insulin resistance. Skin tags, these are all corroborative findings that we can see. We a modified FG score for the hirsutism, that is where it is. The lab test we have spoken about. Ultrasonography, as we have said, that within 8 years of post-menarche, that becomes, you have to be very, very careful, especially in the initial stages. There is no need, because you cannot do a transvaginal sonography. The girl is not sexually active or married or something. So the ultrasound has a very less role when we come into adolescent PCOS. So before going into treatment, I wanted to speak about that. So we have a clear idea in our mind what all we are going to do, what all we are not going to do when there is an adolescent PCOS. And the most important thing, what we see in OPD nowadays, it's the emotional well-being, which is hampered in a very, very big way. The negative image of the body, low self-esteem, not very confident about life, because that is the age group of children, that is the age group of women in which, they have to be the most confident, the most raring to go. And that is what we are going to take care of it. Not just that, okay, she's anxious, okay, she's depressed because PCOS is there. Either we take care of that psychological fact of it, and if we recognize that it is not under our control, we have to refer to her to a particular place, and she has to get treated for it. She has to be motivated every now and then. We have to make her family understand that it is a fight against the syndrome, and all the entire family has to be with it, and not just simply taunt her or make her even more depressed or with more less confidence. We all have to help her out. So in treatment, the various lines of therapy, as we can see, the first, and I think the entire thing that we all the presentations, all these speakers, wherever you hear, it is just lifestyle. It's just simply lifestyle change, and that does wonders. And I think every patient that comes into me also, I said the 70% of the treatment is in your hand. What I am going to give you is just 20 to 30%, and do not depend on it. Depend on yourself. So lifestyle changes, dietary and exercise modification, as we all know, followed by either occipils, control symptoms of the hyperandrogenism. Here also, when it comes to occipils, which occipils are we going to choose? Is it just for regularity of the cycles? Is it required? Or is it just to control the symptoms of the hyperandrogenism? In that also we see, in which we find low doses, the most preferably, what we use, what we want to use is a combination of ethinyl estradiol less than 30 microgram with levonorgestrel. That is much more preferably used than with drospirenone or cyproterone acetate, which has more risks of cardiovascular, deep venous thrombosis and other things. The preferred one is always LNG plus EE, that we can see that combination, even if we are giving in a low dose, that is okay, but not always, maybe to regularize some 3-4 cycles, and that is fine, not on a regular basis, because the age group is also very, very important. Metformin can also be given in patients with impaired glucose tolerance if they're already established that the glucose tolerance is impaired and features of metabolic syndrome already exist, then there's no harm in starting metformin also. But again, the most important being lifestyle change. Just 30 to 40 minutes of exercise, regular exercise per day over a period of 2-3 months. And the motivation to have it and to tell her that that is what is going to take care of everything is very, very important. Or a 5 to 10% weight loss in obese PCOS patients, that is going to do wonders, as we all know. Take care of the ovulation also. So lifestyle therapy, the first line strategy, as we know, weight loss, calorie restricted diet, with no evidence that one type of diet is superior. There is nothing like a PCOS diet. As we see, so many things are being popularized and propagandized nowadays, PCOS diet and this and that. I feel a balanced, good nutritional diet in which you do not have lots of fats and other unhealthy things, that is quite enough for it. It is beneficial both for reproductive and metabolic dysfunction also. And we have to also take care of what we are eating, because, and how is our gut microbiome getting affected, because gut microbiota also gets affected in PCOS. So we have to see that what is happening in us. Are we in a constant state of inflammation in our gut or something, which also triggers a PCOS phenotype later on? Constant triggers, constant alterations to the gut microbiome also leads to triggering of PCOS phenotype in the later years of life. So why lifestyle change? Because obesity during adolescence, an important factor that conditions the evolution of the ovarian function. So childhood obesity or adolescent obesity definitely is another triggering factor that would decide the course of your ovarian function later on. So weight loss, at least 2 to 5%. It has even come down. Simply 2 to 5% can do wonders. Decrease in testosterone by 21%. It leads to that, and resumes regular ovulation in more than 50% of the women. Exercise in overweight and obese women, it improves the weight loss, reduces cardiovascular risk factors and diabetes risk. As we see, there are metabolic disturbances happening. We have to prevent any cardiovascular catastrophe. We have to prevent diabetes. We have to prevent metabolic syndrome taking into place. So we, of course, other things like avoidance of alcohol, smoking, and psychosocial stress. So in this factor, we do advise for physical exercise 30-40 minutes, but we also need to advise mental relaxation and other to reduction of stress, like meditation and other things that can also be a part of the regime. So what type of exercise in PCOS? As we can see, there's so many yoga postures that we can see, so many exercises. It can be simply walking, stretching, jogging, yoga, Zumba, cycling, swimming, whatever form of exercise is okay with you. This type of exercise increases body sensitivity to insulin. It reduces the risk of cardiovascular disease and type 2 diabetes, which I've already mentioned again and again. In Indian adolescents with PCOS, as we can see, ethnicity definitely matters in the affair. We can see it more in the African and other population, but when it comes to our Indian scenario, in which PCOS is also increasing again and again because of the various lifestyle modulations and the changes coming from the Western world, the kind of diet and everything, and the sedentary lifestyle, compared to the control treatment with physical exercise, holistic yoga was found to significantly reduce the T levels, modified Ferriman-Galway score for hirsutism, and improved menstrual frequency. So another RCT on adolescents with PCOS from India found significantly improved fasting insulin and glucose levels, hormone and lipid values independent of their anthropometric changes with yoga practice compared to the conventional physical exercise. So we can see all these things, with a holistic yoga, not just physical exercise. We can see so many improvements in the various scores and the cutoffs that we can take, just not physical exercise. So the recommendations on the non-pharmacological management of PCOS, coming to the dietary part, for the management of obesity in adolescents with BMI more than 97 percentile for the age, it is recommended to follow lifestyle modifications in combination with healthy, balanced diet consisting of regular calorie restricted meals. In adolescent women with PCOS, it is recommended to routinely screen for BMI and waist circumference as an index for increasing adiposity and development of hyperandrogenism. It is recommended to follow calorie restricted diet, low carbohydrate and fat and high protein in consultation with a dietitian or a lifestyle modification as the first line therapy for at least 6 months. And then we can go for adding metformin and other things to it. So as we said, it has to be, first lifestyle change and first identification that we are in that group in which we need special help. We need a very strict diet and a very strict lifestyle. Hormonal contraceptives, as I've already spoken about the various OC pills and other things that we can use, they can be for first line management for menstrual abnormalities or hirsutism and acne. If they exist, we can definitely go for combined oral contraceptive pills containing, 30 microgram or less of EE. Most good combination in this aspect being that with levonorgestrel rather than the other combinations with drospirenone or desogestrel and other things. So it leads to mild deterioration of glucose tolerance. It may lead to worsening of the lipid profile. It should not influence the choice, of course. So we have to be very careful until unless really required. I think it can be avoided. In adolescents with PCOS, it is suggested to use low-dose COCs with or without anti-androgenic progestins like drospirenone, desogestrel for the management of menstrual irregularities. Between 12 to 16 years of age, low-dose COCs only to be used for a very short period, maybe up to 7 days or something. After 16 years, of course, we can give low-dose COCs. Without much hesitation. Menstrual regularity 4 cycles per year in adolescents of 12 to 16 years. That's what, just 3-4 cycles of a year we can regularize it and not keep on giving it for a long duration of time in this age group. In adolescents with PCOS with menstrual irregularity and hirsutism, low-dose COCs are suggested, but with caution. Concerns with the COC, again, common complaints that we can see: hypertension, weight gain, of course, another very detrimental factor, acne also. So in few, we find a 10 mm rise of blood pressure may be there, which settles once the drug is off. Weight gain is not the complication with low-dose COCs, of course. Acne, OCP is, of course, the treatment. We prefer the pill with anti-androgens with progestational activity or maybe a cyproterone acetate pill. Metformin indications, to treat impaired glucose tolerance or metabolic syndrome only in those cases. Long-term resumption of ovulation, especially those with an inadequate response to lifestyle intervention. So this is a long-term resumption in that case. Commonly used as first-line monotherapy or in combination with OCPs or anti-androgens. Only when we are finding an IGT or a metabolic syndrome. Combine metformin and OC, it attenuates the adverse metabolic effects of OC, improving body composition as compared with oral contraceptives alone. So that is where we can use it to improve the body composition and to attenuate the adverse metabolic effects. Duration of the HC or metformin not yet has been determined. How much can we give? Until the patient is gynecologically mature, 5 years post-menarche, or has a substantial amount of excess weight. Topical applications: based on the clinical presentation of acne in the individual patient, specific topical medications for mild or moderate acne and maintenance therapy should be prescribed in consultation with the dermatologist. So if you're really going to find very aggressive acne, something that is really causing a problem, it can be with a consultation with the dermatologist. And benzoyl peroxide, topical retinoids, and topical antibiotics are used as the first line of treatment for acne management, as we all know. Management of alopecia. Although there is limited evidence on the management of alopecia, COCs and androgen blockers can be used to reduce it. It is essential to determine and include and exclude etiologies that mimic alopecia. So we need to know the alopecia is due to PCOS or not, and also exclude other etiologies of alopecia, any immunological factors and other things. In a study on alopecia in general population, cyproterone acetate and ethylene estradiol demonstrated a marked improvement in alopecia, the success rate being around 55%. In another study, CPA for 6 to 9 months demonstrated a marked reduction in the hair loss, hair thinning, and seborrhea in androgenic feminine alopecia. Recommendations on management of depression in PCOS. In adults and adolescents with PCOS, it is recommended to routinely screen for depression and anxiety with appropriate psychological instruments. In patients with PCOS evaluated with depression and or anxiety, psychological counseling by an appropriate professional is suggested based on the severity of the disease. Our duty is to detect it, is it there or not, or whether these symptoms or the other things are leading to it or not, give a proper psychological counseling and a psychotherapy. If not under our control, definitely to refer and make sure she takes the treatment, because this can be a very serious factor apart from the other things that she's going to have. Coming to sleep, which is very, very important, PCOS patients experience sleep disturbances, including excessive daytime sleepiness, sleep apnea, and insomnia. Lack of sleep increases the activity of hormones that drive hunger, such as cortisol, which cause to eat more throughout the day. So that it leads to an eating disorder, also sleeping disorder leading to an eating disorder. Insufficient sleep is associated with a higher risk of being overweight or obese. A review of 18 studies found that those who slept less than 5 hours per night were significantly more likely to be obese. The study demonstrated that every hour of additional sleep per night was associated with a decrease in body mass index of 0.35 kg per square meter. So that is how important sleep is. And various studies have proven the reason for weight gain and also in reduction when sleep comes in. Studies have linked better quality sleep to fat loss. In one study, healthy adults who slept less than 6 hours per night had a 12% higher risk of developing belly fat compared to those who slept 6 to 8 hours a night. Coming to another big aspect in which, because rampantly we see all of us writing ionocetal, Ionocetal and other things. So why do we do that? Ionocetal deficiency is the root cause. Many studies have found that PCOS women have ionocetal deficiency. There is a 5-fold increase in the excretion of ionocetal from the kidneys as compared to non-PCOS women. As we know, phosphatidylinocetal 3 kinase is responsible for insulin uptake and reduce the insulin resistance. So the deficiency of this in PCOS, there is a deficiency of this. There is a decrease in the PI3 kinase, and ionocetal replenish PI3 kinase in the cell and uptake of insulin, leading to reduction in the insulin resistance. Coming to the role of MI and DCI, ionocetal is converted to D-ionocetal by epimerase enzyme. Around 15 to 20% of MI get converted to DCI. The decrease in MI also causes decrease in DCI. It is appropriate to give a combination of MI and DCI in 40:1 physiological ratio to have a synergistic activity, as most of the pharmacological formulations that we have are having this 40:1 ratio. So what happens exactly? This is the pathophysiology. As we can see, it affects the insulin signaling. The insulin receptor resides in the cell membrane. When its beta subunit is phosphorylated by the insulin receptor substrates are activated. The PI3 kinase docks to the insulin receptor substrates, which then leads to phosphorylation of the phosphatidylinocetal, eventuating in inulin action. Ionocetal increases insulin sensitivity by making more phosphatidylinocetal available. So that is how it works. That is how MI and DCI work, by increasing the insulin sensitivity, by making more PI available. Ionocetal levels are very low in PCOS patients compared to normal subjects. That is how we come to know that the deficiency leads to PCOS. As we can see, plasma ionocetal PCOS subjects and normal subjects, it is quite low in PCOS subjects, 0.1, that being 0.19 or around 2, just half of it. And 24-hour urinary ionocetal, we can see PCOS subjects having 2.3 and normal subjects having just 0.7. So MI and DCI in PCOS, as we can see, 40:1. What does it do? It restores fertility. It normalizes the insulin signaling and glucose metabolism, leading to diminishing of the insulin resistance. And normalization of the insulin signaling and glucose metabolism leads to insulin levels being normal and weight loss to start. And MIDCI in 40:1 ratio, what else does it do? The LH levels come down to physiological levels, leading to menses being normal. The inflammation of the ovarian theca cells also comes down, which leads to androgen levels to come down to normal levels. So it acts at various spheres on the insulin, on the ovarian theca inflammation, on the androgen levels, on the LH levels, and that is how fertility is also restored. So these are the various studies in which we can see Ionocetal used in the treatment of the teenagers affected by PCOS and how it has helped. So the conclusion in this being the administration of MI is safe and effective to prevent and correct the metabolic disorders in the teenagers. Combining MI with OC pills, anti-androgenic effects are enhanced and negative impact of OC pills is improved. So that can also be used in combination with OCPs. Efficacy of Ionocetal in the treatment of cutaneous disorders in young women with polycystic ovarian syndrome, another study. And we can see that both hirsutism and acne decreased after 6 months of therapy. Bioadministration is a simple and safe treatment that ameliorates the metabolic profile of patients with PCOS, reducing the hirsutism and acne. Another study in which has seen the effect of Ionocetal on menstrual irregularities and skin problems in polycystic ovarian syndrome cases. Total 75 PCOS women were enrolled. Average age group was 21 to 25 years. 94.6% of the cases with abnormal menstrual cycle was there, oligomenorrhea and menorrhagia and amenorrhea. So what were the results? 74.6% of the cases had improved menstrual complaints, improved oligomenorrhea, menorrhagia in 88% of the women, and 77% of the cases of oligomenorrhea achieved regular menses. So the conclusions are, this study confirms that Ionocetal reduces insulin resistance and improves menstrual irregularities of PCOS cases. But there have been many studies and many practitioners also do tell us that maybe Ionocetal, Ionocetal do not have a role to play, but there are studies which also support it, and we do write it in our OPD practice. So what are the 4 pillars of PCOD management with MIDSI? 4 gram per day is optimal for MI. MIDSI optimal ratio is 40:1. Taste and acceptability by patients impact the efficacy, that is compliance is okay. Formulation, the tablets or capsules have lower absorption and can alter the efficacy. Else the results are not satisfactory. So we have to see the dose, we have to see the ratio, the compliance and the formulation. Then only I think we can get satisfactory results. So the level of clinical evidence, as we can see, we can see in various levels in this review of level 3 evidence case control study, 4 gram formulation, more than 90 of it, going up to level 1, that is meta-analysis of homogeneous RCTs, randomized control trial, more than 7 are present. So the level of clinical evidence is quite high. These evidences have driven international consensus also, as we can see published in the European Journal of Obstetrics and Gynecology and Reproductive Biology. Clinical data demonstrate efficacy of Ionocetal, Ionocetal in the treatment of PCOD. These evidences are strongest for dose of 4 gram per day. Current COVID scenario of adolescent PCOS. Effect of the COVID era on the adolescent youth with PCOS. Polycystic ovarian syndrome is a lifestyle disease, as we all know, in which lifestyle is a detrimental factor in development of PCOS and its management. Increasing youth physical inactivity, sedentary behavior, and unhealthy habits during outbreak of COVID led to short-term and long-term impacts on the different aspects of their health. In addition, the COVID outbreaks may have a trigger on the occurrence of mental health disorders and emotional disturbance, as we all know, in all age groups and in all populations we have seen this. On the other hand, quarantine related to COVID pandemic associated with the lack of peer contact, limitation in leisure time activities in adolescents. So it seems that change in the lifestyle has affected the clinical presentation of PCOS and leads to an increase in the poor hormonal and metabolic profile in adolescents with PCOS. So they may experience the severe symptoms of menstrual irregularity, weight gain, and dermatologic changes like acne, hair loss, and hirsutism. So turning the threat of SARS-CoV-2 crisis into an opportunity for a better lifestyle in adolescents with polycystic ovarian syndrome. So what has happened? How are we going to fight it? Generally, it seems that the lifestyle changes regarding the COVID pandemic may elevate the risk of PCOS in adolescents and worsen the clinical presentation in adolescents with a previous diagnosis of PCOS. The adolescent parents and healthcare providers should strive to support the adolescents. We have to give a physical, emotional, and psychosocial support to the parents and as well as their children. So the parents and clinicians have a key role in the turning the threat of COVID crisis into an opportunity for a better lifestyle in adolescents with PCOS, because earlier things were different. Physical exercise was much more. We did not have social media. We did not have mobiles. We did not have tablets or laptops. So I think that it's a lifestyle disorder, like we have diabetes and hypertension. So we have to deal it in with that way. And genes are loaded in the gun, but lifestyle is the trigger. This is the line that I always remember and tell my patients, that you cannot do with what your parents have given you, what genes you have got, but lifestyle is the trigger. That is how you're going to, whether you pull the trigger or not, how you pull the trigger, what kind of this thing you have, it depends on you, because you cannot change what is loaded inside you. So what are we going to do in the management of the steps with the PCOS in the COVID time? We can take steps to improve the lifestyle, avoid the installation of unhealthy habits, motivate the adolescent to have a regular time for sleep, waking up, and meal meals. Why this is so important and emphasizing on that? Because just lifestyle change can treat 70% of your patients, and we do not have to get into the other scenes of prescribing drugs for other things. So I think this is what we have to know. This is what we have to tell them. To tell them to have a home-based physical activity, body weight training, active gaming, a personal physical trainer if the person can have it, a dietitian support, healthy eating behavior, regular consumption of fruit and vegetables. Parents provide reminders for required tasks for them. Healthcare providers help to manage the symptoms and reduce stress and anxiety related to the clinical presentation of PCOS by, various webinars, social networks, and other things. And also to tell them that, reduction of stress by meditation and other things is also under the control, like physical exercise and weight and other things are under the control. Importance of exercise for adolescent PCOS and COVID situation. As we can see, these are the various, articles that have been there. Supervised aerobic exercise at home has a favorable effect on the psychological state of adolescent girls with PCOS and can be recommended as a safe therapy for these patients in the COVID pandemic. What are the various factors increasing the risk of severe COVID also? So why that is equally important, and it is there is a synergistic role in it. Obesity, hypertension, type 2 diabetes, metabolic syndrome, ethnic minority group, high cytokine levels, high androgen levels, low vitamin D levels, factors increasing the cardiometabolic risk in PCOS. So what are the key points before we end it? So the diagnosis of PCOS in adolescents should be based on the presence of clinical and or biochemical hyperandrogenism and irregular menses at least 2 years post-menarche, not giving much attention to the sonographic findings. PCOM on ultrasound is not a diagnostic criteria in adolescents. Patients who present with irregular menses without clinical and or biochemical hyperandrogenism can be labeled at risk for PCOS. These patients should be followed longitudinally. Severe acne, obesity, insulin resistance, and hyperinsulinemia are common in PCOS but are not a basis of diagnosis. During diagnosis, clinicians should be aware that features of PCOS can overlap with normal puberty to avoid overdiagnosis and unnecessary treatments. Treatment options include cosmetic hair removal techniques, combined oral contraceptive pills alone, combined with metformin and other anti-androgen agents, or metformin alone for patients with metabolic abnormalities. Or any topical, formulations for your various skin manifestations. No single universal treatment can be identified that is efficacious in all adolescents with PCOS or at risk for PCOS. Hence, individualized treatment is preferred. As I said, also a customized criteria which we make in our OPD, and an individualized treatment for each and every, considering each and every patient, each and every adolescent is different, is important for making the correct management of PCOS, rather than putting it into a criteria, putting it into this group or that group under that criteria, under this management. I think it has to be an individualized and a customized approach towards each and every patient. I think I was able to highlight much about PCOS and other things, and I'll be grateful if I have connected with the audience and tried to send some message at least regarding what to do for adolescent PCOS and what not to do for adolescent PCOS. Thank you so much.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, ma'am, to check the questions if any in our dashboard.
Yeah, sure.
Madam, if you allow me, then I can take these questions.
Yeah, sure. Go ahead.
Ma'am, one question is that is as PCOS women struggle with mood disorders, including depression also. So to lower these mood issues that manifest as irritability or lethargy or short temper, is there any treatment strategy apart from the other things that is taken care by the for this ovulatory
I
dysfunction?
think again in this, when it comes to treatment, I think physical activity is very, very important, because when we exercise or something, we have endorphins being released and all that. There are different levels of the levels of serotonin and other things in the brain. They do have an effect on that. So automatically the mood gets stabilized. Automatically the anxiety or the depression comes down. I think physical activity and exercise is very, very important in that aspect. We can definitely guide them to undergo 30-40 minutes of rigorous exercise along with the holistic yoga or with some meditation, which would, before going into a proper psychotherapy or a counseling or anti-anxiety or antidepressants, I think this is the best treatment for that, a natural way of treating anxiety and stress.
Thank you very much, ma'am. Another question is ma'am, as we all know that OCPs are the first line treatment to improve these clinical symptoms of androgen excess in acne, hirsutism. But some adolescents are not comfortable into some side effects associated with the OCP. So on that patient, what will be your first approach to take care of this PCOS except these OCPs?
See, as I said, OCPs we are not going to rampantly write it for everyone possible. As I already said, we may write it if there is a lot of androgenic effects like hirsutism or acne. We can write for them. We can write just to regularize some 3-4 cycles a year, not each and every cycle. So I think the first line again is lifestyle change and other things. We have to see where we have to give it, and only for a short period of time, not on a long-term basis, so that they're not bothered much with the weight loss or the water retention and other things. And also to counsel them and tell them, see, these are the things that you may have as side effects of OCPL. So is it your choice? Are you prepared for it or not? As we have a cafeteria choice and other things, these are the things we can give you. So I think the Ionocetals can make a better role in it. We can combine it with OCPLs, low dose OCPLs, as I said, only in those particular situations, not in everyone. We can rather go for a lifestyle change and give Ionocetals to people rather than going for OCPLs.
Thank you very much, ma'am. So, ma'am, I could not find any other question right now. So, if I get any, we will be back to you back. So, thank you very much, madam, once again for your valuable time on discussion on this very emerging topic that is adolescent PCOS. And in future also, ma'am, we will look forward for some valuable session, medical session with you.
Yeah, sure. I just wanted to know that you're going to put it on Shield Connect. We got that disconnection in between, so that will be eliminated, right? When you're going to put it there.
It is, ma'am, in YouTube already. It is live streamed, so that part is
I was
also
talking on that platform of Shield Connect, that we had that 5-10 minutes of disturbances. I think that would be eliminated, right? Once you put it.
That I have to check, ma'am. That I have to check.
Yeah, that'll be easy because there was a disconnection.
Sure. Okay, I'll be checking, ma'am. That
can be eliminated. That will be nice.
Yes, this is the first time only this happens, so I will be checking, obviously.
Yeah, sorry for that internet connectivity, because the power went off, so that was the problem.
I'll be taking care of that.
Okay.
Thank you very much, ma'am, once again for your valuable time on
Thank you so much. Thank you.
Take care, ma'am.
Thank you.
Yeah, ma'am. Thank you, ma'am.